morning, everyone. Welcome to Distinguished Visiting Lecture Series. We have a very special one this morning, and it's an exceptional pleasure for me to be able to introduce Tom Insel as today's speaker. As I'm sure you all can well imagine, thinking about how to introduce Tom can be challenging. On the one hand, he's someone that everyone, especially in academic psychiatry, knows, so he's literally the man who needs no introduction. But at the same time, as you look through his list of accomplishments over the course of his career, it is so deep and so varied that I could take the entire hour just reciting individual sections of his CV. But I am very conscious of the time today, so I want to keep this short, but want to offer a couple of personal observations. So in my view, it's hard to think of anyone who's had a broader and deeper impact on our field over the course of a career. First as a physician scientist, making seminal insights into social cognition, and then as NIMH director, and then an advisor to Governor Newsom, and now working to galvanize first venture capital and now philanthropy to support mental health. I would add that Tom is joining our volunteer faculty to help us marshal our expertise and develop our centers of excellence in public psychiatry, and we're tremendously excited and grateful for his willingness to do so. I have to say, throughout his career, Tom has combined highly competent empathic leadership with extraordinary vision and risk-taking. At NIMH, he didn't just challenge the DSM nosology, but actually worked to do something about it. He stuck with big bets on genomics and neuroscience, despite, I think, a pretty predictable journey from unrealistically high expectations to disappointment and criticism, both from within the field and among some advocacy groups. Of course, I have a personal horse in this race, but being as fair and impartial as I think I'm able, there's just no question that the understanding of the molecular and cellular underpinnings of severe mental illness and neurodevelopmental disorders has advanced profoundly from where it was when Tom took over at NIMH. And despite, I think, what we all recognize as progress that's too slow for us and our patients, I do believe that we'll look back on his tenure as a critical juncture in what will ultimately be a successful path to novel rational therapeutics. More generally, what I've found so remarkable about Tom is his ability to conceptualize the biggest challenges in our field and then figure out a way not just to write white papers about it, but to actually take them on. And now he's turned his attention to the central challenge of our time, the crisis in mental health care delivery in the United States. As one has come to expect from him, he brings a combination of extraordinary rigor, thoughtfulness, encyclopedic knowledge, self-reflection, to this problem, and he's done throughout his career. He's not only thought deeply about this, but he's arrived at an actionable agenda, one that spans from neuroscience to social justice. So I think perfect match for a proud graduate of our UCSF residency. I'm thrilled that he's here today to talk with us about his new book. It's entitled Healing: Our Path from Mental Illness to Mental Health. Tom, so grateful that you've agreed to come and talk with us. We'll hopefully leave about 10 minutes at the end, and I'll moderate a Q&A for those of you in the audience. Please feel free to use the public chat, and we'll also be able to take you off mute if you raise your hand, and we'll get to your questions. Tom.
Matt, thank you. Gosh, for that introduction, I can only disappoint. and I should say, by way of starting, that this whole long, now 45-year journey began right at UCSF as a resident, and still have lots of friends at UCSF. And my only regret about doing this morning is that we're doing it on Zoom instead of all being together, where I can catch up with a lot of people I haven't seen in a long time. So hopefully there'll be another opportunity for that, when we'll call that post-pandemic. We'll find a way to do a reunion, but delighted to be here today and sort of to really share with you a little bit about what I'm thinking about, and love to get some feedback, hostile or non-hostile, about where my own journey's going. So with that, let me share some slides. I kind of hate to do this, but I'm going to go ahead and move into slide sharing mode, and hopefully you can see that okay. As Matt said, the title of this is Healing: Our Path from Mental Illness to Mental Health. That is, in fact, the title of the book that'll be out I thought it was going to be out in 2 weeks. I just got a note before this meeting started that it's delayed yet again. This is the world of supply side challenges. So even books are now affected, but it'll be out certainly in February, probably by the 22nd. First, some disclosures, and actually maybe more to the point, a disclaimer. I'm not going to talk about anything that's on any of these disclosures. These are various for-profit and nonprofit groups that I've been involved with, and that's not where we're going to go this morning. I'm also not going to talk about DSM or RDoC or NIMH or lots of the social neuroscience that I'm passionate about. What I do want to focus on is a problem. We'll call it a conundrum. It's something that I've struggled with for the last, let's say, maybe 6 years since I left the NIMH, and it's one of the reasons I left. And it's this real fundamental problem that the last 3 or 4 decades, I think we have seen just extraordinary progress in science, and I'll include behavioral science, I'll include technology in that. We've also, to my way of thinking, developed or already had interventions that are actually quite effective. We don't give ourselves enough credit for this. And I'm not talking about medications so much as rehabilitative interventions, things like ACT teams and supported employment, things that actually work pretty well to help people recover. We have psychological interventions and cognitive therapies. For virtually every problem we face, not all, but for most of them, we have things that are effective. And we have, according to SAMHSA, more people getting more treatment than ever in the history of this field. So lots to celebrate, except outcomes aren't any better. And I'm trying to figure that problem out. Why is it with so many positive things to crow about that at the end of the day, we haven't really changed outcomes in the sense of public health outcomes, looking at morbidity and mortality. The journey to sort of answer that question became the book that will be out in February. And I'll introduce that by saying that kind of much of what went into the book was the result of spending a year working for the governor, traveling around California and then ultimately around the United States and the world, trying to understand, trying to answer this, basically, trying to figure out why we had this gap between progress in science and progress in the real world of mental health. Let me just defend that point. When I say there's no reduction in morbidity or mortality, I mean this in terms of the numbers we have. Now, to talk about morbidity, we usually use the disability adjusted life years. Many of you will know about this is a kind of single metric to try to capture years lost to disability, years lost to early mortality. It's not perfect, but when you begin to take the data that the Institute for Health Metrics and Evaluation at University of Washington have put together, you can see that neuropsychiatric disorders are now kind of leading the pack, unfortunately, for almost all areas of medicine. And for me, what that is really indicating is partly prevalence as an issue, but it's all these other issues that we want to put into that category of morbidity. So it's unemployment and homelessness and incarceration, reductions in life expectancy and overall poverty. Those are all things, by the way, that have not improved markedly. And even in my career, over the 45 years that I've been thinking about this problem, it's difficult to find data that would suggest that this isn't the worst time for people with serious mental illness in terms of incarceration and homelessness, and even reduced life expectancy and poverty. The figure for unemployment is about 80% unemployed, which has not changed very much over the last 3 to 4 decades. The other part of this, of course, is mortality. And here, I think if you look at other areas of medicine, at least in my career, it has been stunning to see what we've accomplished in terms of areas like acute lymphoblastic leukemia, the most common form of cancer in children, which was when I was in training was 90% fatal, and today is 90% curable. AIDS has become a chronic disease, heart disease mortality is down 50%. We could go on and on. The point to make here, though, is that by contrast, suicide mortality is up about 33% since the turn of the century. In the United States, actually in other parts of the world, suicide mortality has come down quite a bit, but we're a bit exceptional in that sense with still increasing rates. And that's not even referring to the problems we have with drug overdoses. And many of you will know these data far better than I do, but I borrowed this image from the New York Times 2 years ago, showing that even at that point, when the overdose rate was in the 60 or maybe 70,000 mark, we were looking at numbers that have already surpassed the peak levels of deaths from car crashes, HIV, and firearms in previous years. So really extraordinary. And of course, since then, as all of you know, this number has just continued to climb. The most recent data we have, we've now surpassed 100,000 overdose deaths, a huge increase during the pandemic. Now, it's probably best to put those two numbers, the suicide numbers and the overdose deaths, along with alcohol-related deaths together in what Ann Case and Angus Deaton have called deaths of despair. I actually do think that's a useful construct for us because these are all related. Sometimes it's not quite clear whether a drug overdose is in fact a suicide or not. And so understanding these numbers in aggregate is probably quite helpful and important to recognize that, again, the metrics are going in the wrong direction, that there is a more than a doubling since the turn of the century in terms of deaths of despair. And of course, a massive increase, as I mentioned, during the pandemic. It's a little misleading because there are new ways that the CDC codes out alcohol-related deaths, including something more than cirrhosis. Now they're looking at deaths related to auto accidents and other things. But however you want to cut it, the numbers are just stunning. And if it weren't for the fact that we were in the middle of a pandemic that's taken 800,000 lives, we'd have to reflect on numbers that are probably surpassing almost every other source of medical mortality. And just as a reference point, even if you use the original alcohol-related deaths numbers and you're in the kind of low 200,000s or 200,000 area for deaths of despair, that is greater than the number of deaths from all wars in my lifetime. The Korean War, Vietnam War, all of the wars in the Gulf and Afghanistan put together. So these are big numbers, and they're numbers that are going, as with everything else we've been talking about, in the wrong direction. So why? Why do we have this crisis? Well, then the year that I spent talking to people about this, I heard a number of ideas about this. We don't know enough. We don't have enough therapists. It's always a workforce problem. The treatments don't work. We don't spend enough. And of course, everybody ultimately wants to talk about stigma. I'm going to suggest to you that none of these are the right answer, that in fact, we never know enough, but that hasn't kept us from making big progress in other areas of medicine. I always hear that we don't have enough therapists. There's this supply-demand gap. Actually, SAMHSA reports out we have over 700,000 people in the mental health workforce, well past double what's in the primary care workforce. Do we have effective treatments? I've already said, I think we do for most of the problems we have to face. Our spending has gone up 51% since 2008. That's surpassed well past $200 billion for mental health care. That's for the care. If you add how much we're spending on indirect sources like SSI, SSDI, homelessness, and incarceration, the numbers begin to push towards $1 trillion. So I don't think it's a problem of not spending enough. We're spending it on all the wrong things. Stigma, we can talk about this. It's one of my least favorite words. I think it's a word that has actually not served us well. I'd prefer to talk about discrimination, and we'll get back to that later in this presentation. So if those aren't the sources, So why are we in this mess? What's this care crisis about? And I think it is important to call it out. It's unlike the COVID crisis, which is the emergence of a new disease. This crisis isn't really about an increase in prevalence. It's about a decrease in care. It's about a failure to do the things that we actually know how to do. And I'll say that there are three parts of it that I think are really driving the problems that we're facing now. One is lack of engagement. And this is very different than what one sees in other areas of healthcare. At least depending on how you slice it and what demographic you look at, more than half of the people who would improve and should be in care are not. And the sicker they are in mental health, often the least likely they are to engage in treatment. The quality problem is stunning in our field, and it's one that we should stay very focused on if we're going to try to bend the curve for morbidity and mortality. When people do finally seek care and get it, what they find is a very broken system that is I don't call it a healthcare system, I call it a sick care system. It's focused on episodic reactive care, waiting till you're in a crisis to be able to prove medical necessity to get what you need. And finally, this is a field without accountability. We don't measure, and if we don't measure, we don't manage well. Let me unpack each of these because I think they're worth saying a little bit about. On the engagement front, we've got about 14.2 million people, according to SAMHSA, that have serious mental illness, the most recent numbers that we have. And this was a slide put together when I was still at NIMH by the services research folks. And I really thought it was very helpful for me trying to understand this problem. They pointed out that based on some of the NCSR data from the early 2000s, only about 40% of people who should get services get them. About 40% of those get what we would call, or what Ron Kessler called, minimally acceptable care. And of those, about a third get full benefit, a third some, and third really don't respond very well. I call this the 40-40-33 rule. And I think it's important for us to understand. I was just before COVID, I was at a party in San Francisco, and I ran into a person who had been a resident with me at UCSF. And I was thinking about this problem, and I said to him, "Why do you think we haven't done better?" And he said, we have. He said, "The people that I see get well, and the people that I see today do better than the people I was seeing 20 years ago." And I get that. I actually think that's true. But he's like way down here, right? That means that this number is going from, well, let's see, a third of 40% and 40% means it's about 5 to 6%. He might be able to bump that up to 7%. And maybe we do have a kind of a marginal effect down here. But the big problem is, of course, that people, particularly the people who need the care the most, aren't getting into care at all. When they do get into care, who do they see? Well, we asked Myrna Weissman many, many years ago to take a look at this question of why psychological treatments that people were getting were often not evidence-based. We have perfectly good treatments, including one that Myrna developed herself, IPT, but there's, a host of three-letter acronyms that describe psychological treatments that have rigor behind them and have been shown to work. And yet, when she went out to training programs, and I'm sure UCSF's an exception, and she looked at what psychiatrists, psychologists, and social workers were being trained to do, as you can see here in the right side of the graph, that 50% of psychology training programs and 60-some% of social work training programs had zero training in any evidence-based psychological treatment, meaning that most of the people who you would likely see if you were seeking psychotherapy would not have any training in anything that we know works scientifically. Hard to imagine that state of affairs in the treatment of cancer, heart disease, or diabetes, but that is in fact what people find when they look for care for a psychological problem. This is a little bit complicated to follow, but I'll try to simplify it by saying that we do have these metrics like HEDIS measures, and we have them across medicine, and there are 22 measures for behavioral health. The top three here represent a cardiovascular measure of interest that I tracked when I was working on the book. And that particular cardiovascular measure is the likelihood of getting on a beta blocker and staying on it for 6 months after hospitalization for a heart attack. And you can see that whether you're looking at Medicaid or Medicare or private insurance, that went from about 65 to 70% up to close to 85, 90% compliance with that measure. By contrast, if one looks at a measure like follow-up within 7 days of hospital discharge for patients hospitalized for a psychiatric problem, the numbers have always been below 60% starting in 2005, and they're not any better. And it doesn't matter whether you're looking in the public or the private sector, there is no improvement over time in the quality of care measured by these standard measures. And by the way, I haven't seen these data talked about, published, worried about by anyone in our field. Lack of accountability, that was that third bullet that I was concerned about. Measurement-based care is still very much an aspiration in our field. Less than 20% of practitioners are actually using measurement in an effective way. And it's even less when you begin to look in the real world of practice outside of academic centers. So we've got a problem because, as I said, if you don't measure, you don't manage. Now, I want to say a little bit about solutions in sort of two buckets. One, I want to talk about technology and whether that can help. And then I'm going to talk about all the ways that technology doesn't help and what we need to do beyond that. But let's first say a bit about the tech part of this. If we go back and just talk about these three problems, the lack of engagement, lack of quality, and lack of accountability, and just think for a moment, just step back from this, you begin to realize that those are things that actually tech companies know how to do really well. In fact, arguably, they do them way, way, way too well. For engagement, they know how to hook people in and keep people involved. And you can imagine creating the kinds of person-centered online care based on all of the tricks that tech companies have developed that actually could begin to engage people, including those people who may not be looking for care or who may, for whatever reason, be avoiding it. Lack of quality. Think about that for a moment. The opportunity to remotely train, to coordinate care in new ways, to connect people between primary care and specialty care, between substance use, and finding ways to bring the data together, bring communication together, and create the kind of convenience that's completely lacking in traditional mental health care. And accountability, we can bring in measurement and eventually move to a world in which people get paid for outcomes instead of getting paid for process or time spent. I'm not going to go through this in detail. I just want to give you one example. This happens to be a company that I have absolutely no connection to, but I've been admiring them. It's called IESO Health. It's a UK company. They're not in the United States at all. But I like them because they're an example of how to address quality issues. We can talk about engagement, we can talk about accountability, but for sake of time, I'll just give you a sense of this one. It's a company that does remote CBT in the National Health Service in the UK for social anxiety and for mild to moderate depression. Every interaction that they do, which is usually text-based or sometimes asynchronous chat, they both collect clinical data and they do an NLP analysis on all communication. And they've been able to build this very interesting training model based on something like 100,000 sessions that allows them to give feedback in real time to both the provider and the patient about things like therapeutic alliance, about engagement, about symptom levels. And the result is by doing that kind of feedback every year, their results have gotten better. It's so interesting because a lot of times we talk about AI and we talk about data and we are very focused on measuring what patients do and how patients feel. But this is actually looking at providers and helping providers to become more effective. And that's what I mean by improving quality. And you can see it works. That is, they've gone from 46% to 67% recovery rates as the engine has gotten better and better and as their own tools have begun to improve. So it's an example of the sorts of things that we can begin doing where technology can help us, I think, to not only train the workforce, but improve the workforce. So it's a whole range of things. I sometimes use um, this drawing to give you a sense of the ways that we can begin to solve for engagement, quality, and accountability. Engagement is, of course, providing this person-centered care with convenience. Think Peloton for mental health, or maybe remote minute clinic for mental health. But providing those evidence-based psychological treatments, as well as maybe access to medication. You can imagine the kinds of peer support that can be built in, that can be done through mobile interventions. And of course, all of that's happened to a large extent during the pandemic as a mandate. But even following the pandemic, should such a thing ever happen, let's hope it does relatively soon, there's still the opportunity to provide mobile interventions that people like and that are built around convenience for the patient more than convenience for the payer or the provider. I mentioned this, the opportunity to coordinate care and to capture data to improve quality, certainly through these um, tech-enabled care management. And then the whole process of digital phenotyping. Others have talked a lot about this, but how we begin to measure how we think, how we feel, how we behave in a way that's more objective and is less burdensome than maybe doing it with rating scales. It could also be done ecologically, so that if you have wearables or smartphone tools, that may be a way to really get a sense of when you could think of this as kind of a digital smoke alarm, get a sense of when somebody's becoming manic or somebody's failing to sleep or somebody's beginning to go back into another episode of depression or psychosis. There's a lot going on. I don't want to spend a lot of time on this. As many of you know, this has become a really explosive area for VC investment, $5.1 billion invested in digital mental health last year. I can't help but mention that that's 2.5 times the size of the NIMH budget. There's a lot happening and hundreds of companies now working on every part of this cycle. To me, the really important piece of it is turning this into a learning engine, as finding ways to actually have the digital phenotyping inform the mobile interventions, which then feed into better care management and creating a learning health system, which we've begun to do pretty well, I think, in the world of diabetes with continuous glucose monitors linked to insulin pumps. But we're just not there in the mental health space, creating these kind of closed loops that are informed by data. We have a lot of work to do and a lot of opportunity, I think, to get better. People ask me a lot about this because there's always, and I can sort of preview or predict the questions. There's questions about, oh, what about the digital divide? What about the lack of privacy? What about, all of the things that can go wrong with technology? And I'm totally sensitive to those issues. I'm also mindful of the benefits that could accrue if we do this in a smart way. And what I've been thinking about lately is that, more than any of the apps or more than any of the digital phenotyping wearable, kinds of stuff, maybe what's going to be most important for us in the mental health care space isn't the products that come from tech companies, but the culture. The fact that what we need to learn from the world of technology is how to build things for consumers, how to use what they call UX design or user-centered design in a way that that we can create something that does engage people better because they're part of the design. It's being built by them, for them, with them. We don't do that in the mental health world, which is very hierarchical. Beginning to collect all kinds of data. Great that we've moved to teletherapy, but we're throwing away 90% of the data that are being offered through those kinds of interactions. And teletherapy 2.0 could look very different by doing the kinds of things that I mentioned with IESO, collecting voice and speech and even face expression, if it can be done with consent, to understand at a much deeper level what's going on with somebody, even when they themselves are not quite aware of their mental state. And then again, using all of this data for feedback to do better. So that's, I think, a piece of what can happen and should happen, and it is happening with lots of investment, lots of entrepreneurism, lots of passion from people who are trying to disrupt the way mental health care is delivered. And I think it's fair to say that um, of all the areas that are going to be disrupted by technology, mental health care is likely to be the one disrupted the most. It's just important to know that we're still at the very beginning. And I think arguably we haven't even begun to use technology to touch the really significant problems that I started with, the problems around morbidity and mortality. And I don't think we have any indication yet that by having more people getting more treatment through Zoom, that we've gotten better outcomes. I don't think the data are there yet, but I'm also willing to say it's a 5-act play. We're somewhere in the middle of Act 1, and we've got a lot to do even to get to Act 2. I want to shift to talk about some of the solutions that are maybe going to be in real time more likely to have an impact on morbidity and mortality. And they're not tech solutions. They're solutions that have to do with policy, with payment. And then what I really want to talk about is that third piece around recovery. And I'm going to go through this quickly because I understand, I just listened to Matt Goldman's Grand Rounds presentation from a couple of weeks ago. And if you heard Matt, you don't need to hear me. He knows much more about this than I do. And in fact, most of what I know from Matt. So the idea that we're going to change the way we do crisis response, beginning with a new crisis number, and I really want to stress we're just beginning, is really critical, that we are in 2022 going to replace 911 with 988. And if we do this well, it'll be not just a number to call, but it'll be someone to come. And he talked about mobile crisis response and what we're doing in San Francisco, and importantly, someplace to go. And again, I think he shared this slide, but it's super important for us to think about this entire continuum and to realize that the problem that we have now with ER boarding and with incarceration, that's a solvable problem. And I can't stress this enough, that for much of my early career, we did not have incarceration and we did not have ER crowding because of psychiatric patients. This is a new thing. And we got there in a very intentional way. We need to get out of it. And fixing the crisis response system is one part of how we do that. I will just refer you to Matt's presentation, which is, I know, available in the archive, and you can hear much more about that. The second piece of this is how we build capacity. And it's just, it's part of this crisis issue is that there's been no place to go. It's a figure from my book that just looked at the history of what happened. And we used to call this deinstitutionalization. We now call it transinstitutionalization. The way we went from having people with serious mental illness institutionalized in hospitals to now being incarcerated in jails and prisons. I just think this is so egregious. It ought to be front of mind for all of us as we think about what we need to change in mental health care. And part of this is simply that we have failed to invest in the facilities that allow people to get health care instead of incarceration. And so we end up trying to figure out how to get them care. within the jails and prisons, which really weren't set up for that. We can do better. And there's a bunch of stuff in the policy arena. I'm not going to go through all of this. Suffice it to say that, again, we know what to do. And we've actually got policies that keep getting in the way. They're incentivizing all the wrong outcomes. And so we need to create the community services. We need to create the institutional capacity to be able to ensure safety and better outcomes for people. The good news is, at least for youth, we've got here in California this historic new initiative. I don't know how much this has been discussed within the department, but it is absolutely extraordinary. A $4.4 billion commitment to transform how we deal with behavioral health issues for people. In California, we're defining youth now as anyone under the age of 26. And this is everything from building up the workforce to a new crisis service across the state. We'll have a statewide information portal. There's going to be, there will be new inpatient facilities. As you probably know, I don't believe there is a bed for children who need acute psychiatric care in the city of San Francisco. I can tell you for certain there are no beds north of Santa Rosa. So we have 16 or 14 northern counties without a bed. I've talked to families in Del Norte County who are driving 7 hours to have their child hospitalized for mental health problems. That's really unacceptable. And I think the governor and the Department of Health and Human Services understands that we need to begin to fix this, particularly with sorts of crisis residential centers that Matt talked about a couple of weeks ago. Finally, we have a problem around what we pay for. And as we like to say, Don Berwick famously says, in healthcare, we get exactly what we pay for. And that's true here as well. We have built a system that, from my eyes, is the most intensive and expensive and in some ways feckless system you could expect. And as a result, since it was built for payers, you get exactly what payers would want, which is not at all what families and patients are going to need. So a question that comes up is, how do we fix that? And one way, I mentioned this before, is to shift to paying for value or paying for going at risk with a population where you look for outcomes. Of course, we have to be able to measure outcomes. We've got this new experiment going on. And again, I don't hear a lot of people talking about it, but it's really historic, the CCBHCs. It's the first time since 1963 that the federal government has decided to make a commitment to mental health care as an area. And so what you see is now 430 centers across the country that are providing this comprehensive care. Essentially, it's the old community behavioral health center or community mental health centers, but with all the lessons learned. And many of those are able to go at risk using prospective payment. So I'm really excited about that experiment as an opportunity to begin to change the way we care for people with serious and persistent mental illness. But I think the most critical thing, at least what I discovered in the year and now several years, as it turned out, that needs to happen if we're going to bend the curve for morbidity and mortality, is we have to change the model. That what we have been focused on, and I think one of the reasons we failed in mental health, is we've been swept away by the things I talked about at the beginning, by the extraordinary successes of our colleagues in the rest of medicine. And we've seen what we've been able to do in cancer and heart disease and HIV. And it's understandable that we would say, we need that too. We should be able to also see those dramatic changes in morbidity and mortality. And yet we haven't. And I think we haven't because we've been doing exactly what they do, but we've been doing it on a problem that doesn't respond in the same way. I like to say that what we've done so much of in the mental health space is is a medical model that was really based on infectious disease, where you've got a simple bug and a simple drug, and you can cure the problem. But none of our disorders are simple bugs, and there are none of them that are going to respond to simple drug therapy, at least with the medicines we know about now. That could change, but what we do know is how to help people with a whole set of other interventions that are more recovery focused. So I want to take about 5 or 10 minutes to talk about this because I think it's just so critical and it's so overlooked. We tend to think that when we talk about health, we should talk about healthcare. And I can't stress this enough that particularly for mental health, it's not about mental health care. It's not how many clinics we have or how many medicines we're on. It's about a bunch of other things. Sir Michael Marmot likes to show this particular slide. It's the metro map in Washington, D.C. And he points out that if you go from the center of the city out just past NIH to Shady Grove, that the 17-mile journey is associated with a 20-year increase in longevity. Now, that's not because people in the Shady Grove NIH area are on more medicines or have more clinics. They may be, but that doesn't really explain this. It's obviously explained by a bunch of other factors. By the way, if you want some sort of reference point for how big of an effect size that is, a 20-year change in longevity over a 17-year span or 17-mile span, I decided to look for what do we have with the medical model that we're able to do in terms of changing longevity. And the best I could find was the use of statins, which is probably the most popular preventive intervention we have in medicine, which changes longevity by about 12.6 days overall, which quite frankly doesn't even get you out of Metro Center if you were following Michael Marmot's metaphor here. He goes on to point out that what we need to be thinking about are all these other factors. Some people call these social determinants, others call them the vital conditions for well-being. There are lots of ways of talking about this. The key that I want to leave you with is that we spend a huge amount on healthcare, which may account for about 10% of the variance in outcomes. And for all this other stuff, we essentially hold a bake sale. Now, I want to share this particular slide because for us, this has real meaning. We talk a lot about equity, and rightly, we're having a reckoning around equity based on race and ethnicity. And it's finally time to really focus on the disparities in health and disparities in so many other areas. I can't help but stress that for those of us in our field, in mental health, there's an inequity for people with serious mental illness. And if we think about them for a moment, the way we do think about racial and ethnic inequities, it's pretty stunning. If they were that's 5% of the population, if they were a racial group, they would be our untouchables. They have a shorter life expectancy, a higher rate of unemployment. You know, they have a 16-fold higher rate of being killed by police. 25% of police shootings are people with serious mental illness. And as I've mentioned, a much, much higher rate of incarceration. And of course, for people with serious mental illness who happen to be people of color, it's double jeopardy. So much of those red bars are accounted for by people of color. But even beyond that, serious mental illness is remarkably colorblind. That is, that irrespective of your racial or ethnic makeup, if you have a psychotic illness, you are in that category. And these are injustices that I think we need to begin to reckon with in the way that we've begun to reckon with racial and ethnic inequities and disparities. And I don't hear us talking about this. I don't hear a lot of conversation or a movement that says the time has come. And folks, this one's on us. If we aren't going to be pointing this out, if we're not going to be talking about this, I don't think anybody else will. I had a conversation about this with a psychiatrist who works on Skid Row in LA. And I asked him about how we get to recovery for people with serious mental illness. And he said to me, it's not that hard. It's just the 3 Ps. To which I was saying, I was thinking to myself, all right, we got Prozac, we've got Paxil. Like, it's not Prolixin. It could be psychotherapy. He looked at me and he finally shook his head and he said, look, it's people, it's place, it's purpose. If you want to make progress, if you want to bend the curve that you keep talking about for morbidity and mortality, talk about people, place, and purpose, all of which have been affected by COVID. Our Surgeon General, Vivek Murthy, wrote a wonderful book about the importance of people, the need for social support for people to recover. And in fact, we know that the absence of social support is a lot of what drives people into the crisis-driven sick care system that we have, particularly people with serious mental illness. We don't talk enough about the needs for social support for people with SMI. Place, equally important, and of course, the fact that poverty is a huge driver of bad outcomes for people with serious mental illness. The recent last month's Surgeon General's advisory, also from Dr. Murthy, claimed that children growing up in poverty are 2 to 3 times more likely to have mental health issues. And this plays out in so many different ways, which we can talk about in the conversation afterwards. Purpose is one, again, we don't engage this at all within our mental health care system. It's a system in which we're the experts and we tell people what to do and what to take and where to go. But in fact, as Marcia Linehan once told me, she was an advisor at NIMH, when we would argue all the time about what to do for people who are suicidal, she'd say, give them something to live for. Don't lock them up. Don't think about that the problem is just safety. The problem is that they need a purpose. They need something to care about. And we've learned how to do this by giving people a chance to use their lived experience to help others. That becomes, in fact, part of a mission. It becomes part of what they have to live for. And an extraordinary experience, one that I had in the last couple of years, is seeing how one of the most powerful therapeutic interventions is giving someone a chance to help somebody else. Something that, by the way, we almost never do in the world of traditional mental health care. So I want to finish up by saying that I think this idea of recovery as a goal is really, it really changes the way we talk about and the way we address both the equity issues and these issues around the failure to make progress on morbidity and mortality. I don't want for a moment to say that we should reject the medical model. I think, in fact, we need to remember that these are brain disorders and they are, in fact, medical problems. We should define the problem as medical and we should expect the same kind of insurance, the same kind of science, the same kind of rigor and standards and quality of care. But the solutions have to be much more. The solutions can't be just medical. They need to be social, they need to be environmental, they need to be political. I'm not sure that's as true in other areas of medicine, but here, until we engage these other aspects, we ain't making progress. We're going to end up just where we've been. We've got to think beyond symptoms, and we've got to redefine what we mean by care. So I'll finish up by saying, I started with this conundrum. Why, with so much progress in so many regions, have outcomes not gotten any better? And I think my explanation and where I came to in the book is that it's not just about healthcare. It's that we've got to start thinking about people, place, and purpose, these 3 Ps. That yes, we can define the problem as medical, but we're not going to bend the curve until we start to have a broader set of solutions. So finally, by summary, we've got a crisis in mental health care, not just a crisis in mental health. We have both. We've got solutions, sometimes tech solutions for some pieces of this that have to do with engagement, quality, and accountability. But if we really want to make a difference, particularly for those people who are the most severely impacted, those with SMI, we're going to have to engage these 3 Ps. We're going to have to think about recovery and create this new model, not simply the medical model. I'll end with that same concept that the problems are medical, but the solutions are social, environmental, and political. And to that end, um, part of what I'm spending a lot of time on now is actually starting a social movement for mental health, very much based on Black Lives Matter and Me Too and other movements that are really making a difference. The book is part of that. It feeds into a nonprofit called MindSite News, which is a platform, a journalistic platform. It's all digital to really kind of define this area between mental health and social justice. And the Steinberg Institute in Sacramento is, of course, deeply involved in many of these issues as well. So I'll stop there. Thanks a lot for your attention. I'm really interested to hear your thoughts about this, as I'm still trying to navigate this space and trying to figure out how to solve this particular conundrum. Thank you.
Tom, thank you so much. Wonderful, provocative talk. And so for those people who are listening on the phone, I will read some of these questions. Tom, you can probably see them in the chat and I'll run through them. And then if you want to raise your hand, we'll try to get to that as well. So first question that we have here is from John McQuaid, our vice chair at the VA. Many of the recommendations you're making are being embraced by the VA system, measurement-based care, integrated coordinated care, et cetera. Although it also has challenges, overall the VA provides as good or better outcomes with lower cost and last year demonstrated a reduction in suicide rate among veterans. Do you have any thoughts, reflections on the role of the VA in facilitating the changes that you're recommending?
Yeah, I have a lot of thoughts about that, but I'll be really quick. The VA is the only real healthcare system that we have in the United States. I'm going to say that in a very provocative way, but I think what we built everywhere else I would call a sick care system, but the VA really looks more like the NHS in the UK. It's a national system that many years ago decided to invest in data and to begin to measure in a way that other systems haven't. I think the challenge for the VA is still the engagement challenge, and there are quality issues as well. So I think they still have some work to do to improve quality, but they are the one system that does seem to be monitoring outcomes. They put measurement-based care in long ago, well before the rest of the United States. They've done a spectacular job of training. In the book, I talk about IAPT and how that was developed in the UK to begin to train every clinician to be able to give an evidence-based psychological treatment. Well, you know what? The VA is the one place in the United States that's adopted that as well. Good for them. And in fact, they've done the follow-up studies to show that that matters. They get better outcomes. So I think VA is a great place. The one thing that has been difficult to get going at the VA is some of the innovations. So I think, what I would love to see is more work between the VA and the entrepreneurial community, particularly some of the startups that have great stuff that's now ready to scale. And they end up working with Optum or Humana, but not so much with the VA because it's a much more difficult negotiation. So that would be something I'd love to see happen in the future.
Thanks. In looking at these questions and seeing the hands starting to go up, Tom, there's no question you're going to have to come back. We're just going to touch the surface, and there's some great questions down here. I think they're very interesting conversations, but I'm going to try to go in order here. So from Christina Mangurian, who you know well, talking about the issue with regard to SMI and health disparities, and she's asking the question, love to get your take and guidance on how to make more noise about this issue, feeling like there's not really tremendous responsiveness governmentally around this question. Any thoughts on sort of how to push this agenda more?
Yeah, so Christina, we may want to chat about that offline. I think there's a lot happening. It's really been amazing to me. There's more interest in these issues in the federal government than at any time in my career, without question. And there's more money coming in. And we now have in California an enormous focus on this. CalAIM, which I should have talked about. CalAIM is historic. It is going to change. It's fundamentally going to change mental health care in California. Now we've got big challenges in the state, terribly fragmented mental health care system. There's no Department of Mental Health in Sacramento. There's no one accountable. But between CalAIM and this huge youth behavioral health initiative, wow, this is the time. And part of why I started MindSite News is I wanted someplace to broadcast this. I thought, it's easy. And when we started, all we were writing about were kids being beaten up by police and incarcerated. And that got very old very fast. And then we brought in Tina Rosenberg, who was the founder of solutions-focused journalism from the New York Times. So she joined us and she said, guys, nobody's going to want to read this. So now we're writing a lot about solutions and about the opportunities, and they're spectacular, including one that's just happening today as a great example. While we've been talking, Marty Walsh, the Secretary of Labor, has announcing the audits that were done last year on parity in the United States for 10 of the largest private companies, demonstrating in every respect their complete failure to provide mental health care to their employees. It's the first time the federal government has ever done anything like this. There'll be a white paper that'll come out of this, and he's doing the briefing as we speak right now. That's the kind of thing we need to start letting people know about and broadcasting. There's a lot going on. It's a really exciting time to be ringing the bell, particularly for people with serious mental illness. Let me help you on that.
Fantastic. We're so delighted for that offer. And as you know, we're going to officially take you up on that. So I'm going to make a command decision and prioritize the asking in person. I do want to say before we get to Eric, though, I apologize for all of you who have these great questions. Again, Tom, we'll have to have you back. And there are a whole series of these that I just wanted to summarize. If you're not looking at the chat, Tom, is 3 cheers. Thank you for this perspective. Thank you for the broad perspective. Wonderful to hear your talk. You might want to get a screenshot of that to send to your kids.
You can thank me by buying my book.
There you go.
And because all the proceeds go to MindSite News, which is just a different way of trying to push this movement forward.
Fantastic. Eric, do you want to bring us home?
Tom, I'm going to try to buy the book for all of our trainees as much as I can. It's just phenomenal talk. I think that there's been such a movement in training programs, and I'll speak more from the medical training programs at least, towards this kind of competency of health system science, in addition to kind of basic science and clinical science that we're teaching in medical school and then, continuing in training programs. But you still see, I think, in psychiatry residency programs across the country, and, I sit on the accreditation board that takes a look at how we're in compliance or not in compliance with programs. It's a very traditional model of how we've been training psychiatrists right now. And so, I think the proportion of how we think about our curriculum and what we train and in the cultures in which we train, need to change now. And so my question is, out of all of these priorities that you see, like, what are the top priorities for training programs across the country to really move towards this health system science and broader approach of really impacting health as opposed to, all the other things that we're training?
Yeah, I don't know that I have a quick or a good answer to that question. I do think it's been really hard to change training of psychiatric residency training, and there've been efforts. There's a really great project underway at Yale, starting at Yale with David Wolf, who's now moving to Alberta, called the Neuroscience Training Curriculum, I think. And that was good because it provided some of the hard science to help support more than just pharmacology. What I think hasn't happened is the kind of stuff that Christina and her team do around public psychiatry. There hasn't been, I have to say, I used to do like 3 or 4 grand rounds a year when I was director of NIMH, and we just go around the country and kind of spread out that experience. And I'd always meet with residents, and I'd always ask them the questions about how many suicides and the sort of morbidity questions, like, tell me these numbers. and they were always clueless. They had like no sense that how bad things are for people in the public psychiatry domain, or how difficult it is to get care. I mean, they're just like really out of touch with where the real world is for a family with a 21-year-old with schizophrenia. They just don't get it. And so part of what I really like to think about is how to help them understand that experience and the part they can play in making things better. And the fact is that we now have solutions that, like the coordinated specialty care clinics that you heard about from Lisa last week, and the kinds of crisis centers that Matt talked about 2 weeks ago. I mean, there's a lot going on that residents need to learn about, and they're not, they're learning like what dose of Seroquel to prescribe, but they're not getting this kind of whole person care perspective. So I think we've got to figure out a way to make that happen. I mean, that it's a national need, not just a training need for the field.
Again, thank you for a wonderful talk. We just skimmed the surface on these questions. Lots of provocative things here. Really, we have to have you back soon. And thanks again. Thanks everyone.
Okay.
And we'll see you soon. Stay safe. Have a great day.
Take care,
everybody.
Bye-bye.